Okay, so my talk, the first talk, is going to be about some general concepts for surgeons primarily. So this is the old one. The issue with mesothelioma is that it's a very unusual disease, and most people, we were just talking beforehand, most people get told that there's nothing they can do. Most surgeons will say there's nothing they can do. There are a few fanatical surgeons that want to do everything and don't want to do a big operation for their patients and do them some good, but in reality, surgeons have to be smart rather than aggressive about taking care of mesothelioma. And the reason for this is that it's a very unusual tumor. It's a diffuse tumor and not a very localized tumor. So lung cancer, colon cancer, breast cancer, all the other cancers, almost all the other cancers that we deal with are very localized cancers. And surgery, which is a localized treatment, is very good for localized things, but it's not good for mesothelioma. And mesothelioma is a diffuse tumor, and some people kind of just don't get that, and you have to kind of accept that and understand that that's the way it is from the beginning. So I have no disclosures other than the fact I'm a surgeon. So in our overview, we're going to talk about why the diffuse nature, which we kind of just highlighted a little bit of mesothelioma. It's a tumor that does not localize very well, and so surgery is kind of problematic. We're going to talk about the implications of having a diffuse tumor for surgical techniques and what we do and the options that we have to do those. We're going to talk about, under that, the completeness of resection, and that is a surgical issue where people can generally, in cancer operations, classify our operations as R0, 1, or 2. R0 is the gold standard, which is removing everything with some normal tissue around it, and then R1 is marginally removing something, and R2 is leaving some of it. So we'll talk about that, and then we'll talk about whether you sacrifice vital organs in your attempt to remove a tumor, particularly a diffuse tumor, and then talk about the implications for diffuse tumors in the extent of the surgical field. We're also going to talk about the implications that we as surgeons need to be aware of for diffuse tumors and with adjuvant therapies and the possibilities for that. And under that, we have the usual induction treatments, what are the implications for that, and interoperative opportunities, pretty much, and the postoperative adjuvants. So definition of diffuse, this is off a Wiki dictionary, whatever it is called. It's basically diffuse, it means everywhere, it's throughout everything. And it's not focused or concentrated, not focal. And this really poses a huge problem for surgeons because we are very focally oriented people. And so when people have, back in the 1980s and before, when you had mesothelioma, surgeons would just throw up their hands and say, we can't do anything because it's everywhere. And that's what most patients get told as soon as they get seen by a surgeon and somebody looks in and does a biopsy thoracoscopically or otherwise. They look and they say it's everywhere. So that's very true, and that's that we have to deal with. So when surgeons have to kind of deal or come up with strategies that take that into account. So going back to embryology, the lung develops from buds that push into the pleural space. The pleural space is the embryologic coelomic cavity that divides into the pleural space on both sides, the pericardial cavity and the abdominal cavity. And those are all areas where mesothelioma occurs. And what happens is it's like your fist, the lung will push into the pleural space, open space like this, and the visceral pleura is what's touching your hand, and the parietal pleura is on the outside. And both lungs kind of push in from the middle into this, so it's like your hand coming from the middle. So you have the visceral surface and the parietal surface, but they are all one continuous surface. So they're not separate entities, and they cover everything, and it's all in continuity. So when you actually do a pleurectomy, you can trace the pleura all the way back around and off the lung and off the outside chest wall and everything else, exactly like you would be if it was a piece of latex balloon. So when you see this, well, I don't know if you can see this very well, but when you look at X-rays for people who have mesothelioma, on the left here you can see that it's a fairly big space that's black. This is the left lung, and you can see the edges are very smooth, and that's because it's a normal chest X-ray on this side. However, on the right side, you can kind of see haziness that goes all the way around the lung. And that's kind of an indication initially by a simple test that there's a process that's diffuse in the pleural cavity. Does the lights go down at all, or no? Because these aren't going to be coming out very well. We can turn off some of the lights, it'd be really helpful. So anyway, this is a CT scan, which is like looking, for those of you who don't read CT scans, it's like looking from your feet towards your head, and the left side of the body is over here. This is the spine, this is the breastbone, and this is the right side of the body. Oh, that's better. Perfect. And if you see on the left side, there's white things that go around here. These are the ribs, and there's really nothing between the black lung here where there's air and the ribs. It's just really thin. On the left side, on the right side, sorry, there's a little thin layer that goes all the way around, and you can trace it all the way around, just like that balloon with the hand in it. You can see it, and you can see how the tumor, at a very early point, actually extends around the entire chest cavity. And this is three-dimensional views with various reconstructions of the CT scan. So this is the one we just showed, and this is one if you look at it from a coronal standpoint, you just cut the body straight up and down, as you look at it, and this is from the side. And you can see in each circumstance there's thickened tissue that goes all around the chest, and it even extends into the fissure between the lobes of the lung. So you can see how, from very early, it's very thin. This tumor extends around the entire chest. So from the very beginning, essentially, it's everywhere. It's a little easier to see in this MRI, which is of the same patient. The MRIs are a little different. They give you some tissue quality to them, so you can tell which ones are relatively normal and which ones have extra water in it that are typical of tumors. So you can see that there's a white area around here that goes around the lung. This is the top of the chest, and it goes down through the whole chest. And you can see that there's a white rim that goes around this entire lung where there's nothing over here. And this is the same thing with 3 dimensions. You can see it in all aspects. You can see on this side and on this side. So this is a diffuse tumor, and this is the correlating PET scan where you can see activity where tumors are, and you can see that it goes around. So basically, from most patients that have this, or I say all patients that have this, have a diffuse process in their chest. So early mesothelioma staging, if you look at the staging system that's currently in place, although data is being collected right now to revise the staging system because it certainly isn't necessarily very accurate. A T1 tumor, which is a staging system, a TNM staging system, a T1 tumor is a tumor that involves supposedly the parietal pleura only, with only maybe focal involvement of the visceral pleura. So is a kind of a concept that people have when you look at patients, when you look in somebody's chest who has early mesothelioma, the nodules tend to be on only the outside edge of the lung, of the pleural space, not on the lung itself. At least that's what you see grossly when you look at it. T1A tumors have basically no visible involvement of the visceral pleura. However, I'll mention something about that in a second. And T1B have maybe focal involvement, so a few little nodules on the visceral pleura. T2 tumors have more confluent involvement, so you see like those Xrays where that would be a clinical T2 tumor. So this is what a T2 tumor looks like. You're not going to be able to see anything that looks normal here, but this is from a thoracoscopic view inside the chest. This is for somebody who had fluid, so there's fluid sitting here that we've taken out. And then this is the lung actually sitting here. It's covered by this white confluent area of tumor. This is the chest wall where the ribs are. You can't see those like you would normally because it's also covered, and here's the diaphragm. So basically you look in there and you can't distinguish any organ because they're all covered by this diffuse tumor. And that's pretty easy to understand. You can see that if you close up, you can see that these are all tumor nodules that are growing all over the place. And plaques also. This is probably a plaque, but the tumor is growing everywhere, and you can see it on everything. So that's kind of an easy thing to understand when you're looking for tumors. But here's a little different view. This is an earlier tumor, so these are little white nodules on what looks like otherwise relatively normal pleura. So in this circumstance, you might think this is a really early tumor. We can kind of find these things earlier. We can treat it. It would be easy just to take this off versus the other thing. And in some patients, if you see, sometimes there'll be just a few nodules scattered here and there. And an interesting thing is that when I train, particularly when this is on the pleura of the lung, we used to dissect each individual pleural nodule off the lung and take it off separately and leave the rest of it because it all appeared normal. And I've had a couple of patients where there's been, when I've gotten inside the chest for mesothelioma, almost the entire surface looks normal. So in most of the senses, you would think that that would be a very early tumor, but we've, in those circumstances, actually gone in and taken out the normal pleura and sent it to our pathologist, and then there's been, they usually call and they say all this normal pleura that looks normal is all disease. So even though if something looks like it's just localized or focal in this one nodule, it's everywhere. So all this surrounding lining is actually all tumor. So it's something that I think a lot of surgeons, and even currently I've heard some surgeons who see minimal disease like this, they'll just take off the nodules. And if you do that, you're bound for failure because you're still leaving a whole sheet of tumor on everything. So I think that's one reason why chest surgeons don't do so well for mesothelioma when they don't understand that. So no matter what you see when you go inside the chest, if you're going to do surgery, you need to take off the pleura no matter what it looks like, and it actually ends up being all disease. I've only had one patient who had normal pleura on the same side as a tumor, and that patient had had a history of pleurisy early in their life and had sealed their entire pleural space. So they had multifocal disease where there's multiple nodules, which is interesting because that gives you an idea that even though the pleural space was sealed, there wasn't any spread within the pleural space of the tumor. It started in multiple areas. So the tumor seems to start from the beginning in multiple, as a diffuse thing, and it's not necessarily a tumor that starts in one location and spreads diffusely. So the surgical technique, so implications for all this diffuse tumor on surgical technique, it has to do with looking inside the chest. So this is the right chest, this is the left chest, and the only real difference is there's a lot of veins on this side and arteries on this side from the aorta. But the lung is removed and you're looking on the inside to see what you have to deal with. And so there's chest wall with lots of ribs and intercostal muscle. There's a pericardium in here. There's some soft tissue up here where the thymus is, and there's a diaphragm. And these are all the normal structures, and the lining is on all these things. So taking it off with any kind of normal margin of tissue would be impossible. You can't really take out all these structures all at once. You can't take out some of them in different locations. So if there is a focal involvement of one more than the other, you can do some local resections, but you can't deal with the whole thing. So you have to come up with a strategy that will deal with all these things equally. Most people really just think about the diaphragm, the pericardium, and lungs. So those are the surgeons that have come up with the extrapleural pneumonectomy concept, where if you go in the chest, you can scrape everything off and then take out the diaphragm, take out the pericardium, and take out the lung because you can. Those are the things that can be removed relatively easily and then replaced and that kind of thing. And so, but there are implications from doing that for diffuse tumor, particularly one that has sarcoma-like properties to it. So back to the classification, surgical classification of the resection. So R0 is the radical unblock resection, where you would take everything out with really 2 to 3 centimeters of margin normally. And that includes removal of other tissues in some circumstances, other like sarcomas at the extremities. You remove muscles and even do amputations if you need to do that. R1 is a marginal resection where you just kind of go right next to the tumor. You think you get it all because you're taking the tumor out, and particularly in mesothelioma and sarcomas, they tend to kind of just fall out of the tissue sometimes, so that you think you're actually getting out within a pseudocapsule, but it's really, there's tumor on both sides. And R2 is when you take out most of the or some of the tumor, but you leave some in localized areas. So in mesothelioma, if somebody says they got an R0 resection, they're lying to you because it's just not possible. So this is, when you kind of think about this, so you have to accept the fact that you're not going to get an R0 resection. There is a group in Boston, the pathologists there somehow look at their specimens that when they take out of an EPP specimen, which is a big glob, and they somehow look at the margins, and they say that they can determine whether they're negative or positive, which is hard to imagine. But I've asked our pathologists if they can do that, and they said that categorically they can't do that because the tumor is right there in the margin. There is no margin. So really, realistically, if you're doing surgery for mesothelioma, you shoot for an R1 or R2. You certainly don't want an R2 because that's not very helpful. So you want to really get a resection where you take out everything that you can see. So all gross disease, they say all visible disease has taken out. So this is kind of a cartoon showing what the real problem is. If you're doing a really cancer operation, this is what you do. The tumor is the white nodule here, and then what you do is you go around it and draw lines around it and take it out with some extra tissue around it. So this is what the ideal would be, an R0 resection. The problem with mesothelioma, that it's kind of like this tumor and this tumor, is you can have the tumor in the middle, but it's always touching the edges where you can go. So you can touch the edge here and here, multiple areas, but you might get a little bit of extra tissue around it in different areas, but basically at some point, or many parts of the points, you're going to be touching the tumor when you do the surgery. And some of this areas could be the lung, for instance. So the question is going to come up whether you take the lung out just to get an extra margin on one side. But wherever the ribs are, essentially, the great vessels, the esophagus, those are going to be margins that look like this. And so really, most tumors, when they're advanced, they look like this. You barely get any kind of margin, if anything at all, around the tumor, and all you can do is get the tumor out itself. So the saying in surgical oncology is you're only as good as your closest margin. So if you do this radical resection and you take huge margins around a big tumor, but you're right next to it in one aspect, it's a failure in terms of a surgical resection. And here's kind of a pathology. This is a pathology slice from a lung. The lung is the pink stuff in the middle, and then right along the edge and into this area, you can see this white tumor that goes around the whole thing. And so one of the issues is, how can you get this off the lung, or do you just need to take the lung out? So again, ideally, if the lung is in the middle, you can take the tumor out, and if you got really good margins, that would make sense. Because if you can actually get everything out and the lung just happens to be in the middle and you can't get good margins on the lungs, then taking it out would make sense. However, this is really the case where you're at. The lung is in the middle, the tumor, white tumor, is around the lung, and then the margins are really marginal. So in that circumstance, in any kind of surgical oncology, people are generally believe that you should not be taking out vital organs. And it's true in retroperitoneal sarcomas and other areas where if you have retroperitoneal sarcoma and it's touching a kidney and you're not taking it out completely, you wouldn't take the kidney out because unless you can get everything out in a radical manner. So people don't sacrifice normal kidneys, you don't sacrifice normal lungs and that kind of stuff. So from a surgical oncology standpoint, it doesn't make sense to do that. So removal of vital organs when you don't have a good margin does not make sense, and it doesn't improve your margin with the lung in particular. Now there is an issue because some people, who I won't name in particular, claim that they can't get the tumor off the lung. And they seem to be able to get the tumor off of the back of the ribs, the other vital organs, the blood vessels and everything else, but they can't get it off the lung. But it turns out most people who do this operation find that getting it off the lung is actually a simpler thing oftentimes, because the lung tissue is very thin and you can just kind of peel it off like a orange peel off of an orange. So the issue of whether EPP, extrapleural pneumonectomy, taking out the lung, actually gets better outcomes than taking out the tumor, like with a pleurectomy when leaving the lung in place, a pleurectomy and decortication, is always been out there. And there are people that have all kinds of different reports in different patient populations. There's no randomized trials, so there's nothing I can sit here and tell you that this is better than another thing. And in fact, I can't even tell you definitively whether surgery works at all in these patients. So if you look at 37 non-randomized trials of using either EPP, or extrapleural pneumonectomy, or PD, and look at their survival, reported survival, as the EPP have a very broad spectrum of where it goes, all the way down from 5 months to 23 months. And then PD is pretty much the same thing, a little less spread, but basically both these operations have a median of most numbers between 12 and 18 months. So you can see there's no difference. There isn't more clustering up here, there isn't more clustering down here. So these basically look like similar scattergrams and similar outcomes. So each individual report can make it sound like one's better than the other, but in aggregate, when you look at all of them together, there is no evidence for one operation over another. And particularly so, this is evidence that taking out a lung doesn't improve survival. And there's been a number of groups that have looked at this, including the International Association for the Study of Lung Cancer a number of years ago, and they concluded there is no data to support using lung sacrificing surgery. So this is kind of what it looks like visibly when you look inside the chest, so you can kind of understand why that might not work to take out the lung, because here is the chest is open, and here's the tumor that you just see. It's covering the whole thing. You can barely get inside the chest initially on some of these patients. And then if you cut through the tumor down in it, you can see the lung underneath of it. So this is a kind of that layer of you saw on the CT scans, the PET scans, and on the various things, you can see this layer that gets thickened. So when you go in there, it's kind of hard as a surgeon to really imagine what you're doing when you have everything closely adherent to the lung, closely adherent to the ribs, and everything else like that. So when you're doing these operations, it's kind of interesting that you can actually peel it off of these things. And here's the lung, here's the same patient with the chest wall, and now the lung, all the tumor is kind of brought up into this big mass off of everything, and this is just before it comes out. And you can see that even it comes out of the fissures, so that each individual lobe of the lung is visible. And in this kind of a case, you can't see any residual tumor cells. They are there microscopically, but you can't see them. So at the end, once you take the tumor out, this is what you have: is you have the lung here, and there's a fissure between the two lobes of the lung. This is the left side, and this is the diaphragm muscle here. You've actually taken the tumor off the diaphragm muscle and left the diaphragm. And one of the issues in doing all this stuff is that you can be more aggressive about taking things out. The diaphragm you can take out. The pericardium you can take out. The lung you can take out, but that's a little different issue. But you can take out these other borderline tissues. But the problem with diffuse tumors when you're doing that is that you have to think of the consequences. So the consequences are potentially that now you have extended your surgical field beyond what you would be where the tumor was to begin with. And if you do that, there are potential downsides. So one of the things that people have talked about with doing EPPs is that they have better local control of the tumor, and tumors recur more in distant sites. So this looks at some recurrence rates for EPP versus PD. So PD, this is local recurrence. This is what I call variable. I'll tell you what that means. And this is distant recurrence. So distant recurrence in most patients for either operation, if you true distant metastases to the bone or to the liver or to other sites, is relatively low. It's only a few percent. But you look at mostly a local recurrence rates, and if you look at PD, the claim is it's about 65% will have recurrence rates within the pleural space where you did the operation. And for EPP, it's actually down to maybe 30%. So it looks like they cut the recurrence rates locally in half. But then there's this group that have been variably classified by different people as to whether this group is actually distant or locally controlled. So when you look at taking out the diaphragm and everything, the thing that's beyond that is the peritoneal space. So right below the diaphragm is the peritoneum, and if you go too far in the mediastinum, like beyond the pericardium, then the other thing on the other side is going to be the other pleural space. So if you look at one typical study, look at an Australian study with 36 patients, only half underwent EPP. And if you look at the postoperative adjuvant, they got usual postoperative adjuvant high-dose radiation and chemotherapy, which a lot of people have used as standard for a long time, and they had no local recurrences. But about 50% of people did recur. And so you kind of look at their analysis of what happened. They had recurrences in the peritoneum, 6 out of 9, and then 3 out of 9 in the contralateral pleural space. So they're classifying this as distant metastatic disease, when in reality, when you have taken out the diaphragm and you've gone into the area right around the peritoneum, that's your edge of your surgical margin. So when you recur in the peritoneum, it's really a local recurrence. So that's the variable kind of nature of how people classify that. So rather than a claim that people make that they're changing the natural history of mesothelioma by doing an EPP, what they're really doing is spreading the tumor to new areas where it didn't exist before. So these are peritoneum and chest. These are kind of the usual typical recurrence patterns in the abdominal viscera and contralateral lung. So all these are the type of recurrences that were basically highlighted with that last Australian study, and also with Sugar Baker's data and everybody else's data, is that they have up to a 50% peritoneal recurrence rate, which does not occur with a pleurectomy because you're not into that space. And so you can't really call that distant recurrences. That's really not metastatic disease when you were just right next to it. So if you reclassify those other ones as local recurrences, then basically both operations end up having the same local recurrence rate. So it's a kind of a little play on what happens in the claim that you're really getting distant metastatic disease is really not true. So I looked at it kind of as a tumor balancing on the top of the diaphragm or on a guide on a high wire, and you're trying to keep the tumor on the top. It's a very difficult process, and if you do too much, like you try to interfere with what's below it on the wire on this building, you end up dropping the tumor onto below that, which is the peritoneum. So it's kind of one way to think about it. It's very tenuous, and if you do too much surgery for a reason that you think is good, but you don't understand, you're going to actually create a bigger problem and lose the game. So the things that we need to consider with adjuvant therapies in terms of the diffuse nature of these tumors is that other tumors that are localized, like pancreas tumors and rectal cancers, they can be treated with preoperative radiation and get better. And there's, until recently, there's been very little interest in doing that with mesothelioma because it's just very hard to treat the entire chest. But recently there was a SMART trial from Toronto that suggested that maybe this kind of approach could work in mesothelioma. It's just been technically very difficult, and you're going to hear a little later from Percy Lee about the kind of advances in radiation that maybe allow this to happen. But it's not been really a good approach for mesothelioma up to this point. But the SMART trial, as I mentioned, suggests that maybe preoperative radiation may potentially have benefits either in just kind of tumor control at the edges or potentially in other things like immunology and immunologic reactions. In terms of the cons, radiation cons, those are the pros. Gross disease is always going to be hard to control with radiation. In many instances, when you try to treat gross disease with radiation only, it doesn't really seem to do very much. So it's conceptually hard to think of why doing induction therapy with radiation would be helpful, because it's not going to control the whole thing. It's not like rectal cancer where it can actually shrink down and almost totally go away or sometimes go away. And it's a large area, like I mentioned, with significant toxicity unless you have really good ways of doing radiation. Chemotherapy before surgery has been used quite a bit. We'll talk about that. Actually, Dr. Alevsky will talk about that a little later. It can be useful if it works. If it doesn't work, then obviously it's not going to help the patient. And one of the biggest problems with treating anybody before surgery is your ability to assess how you're doing. And these tumors also have a lot of fluid associated with them and swelling. So when they get treated, some things can improve, like the fluid, and then the tumor actually doesn't improve. So people have had typical ways to assess cancer in the chest, which is called the RECIST criteria, which is based on lung cancer, essentially. So you can measure tumors, they get smaller, and you can tell how much smaller they get. But with this kind of thing, like you saw with the other pictures, it's a very thin layer, and it's hard to tell when something gets substantially better, or at least a little bit better. And so it's really hard to assess what the response has been. And typically, at least until recently, the response rate is pretty low. It's only 30 to 45% at best. And response doesn't necessarily make surgery easier because the tumor is actually still there. And some people think that chemotherapy responses can make the tumor harder to take out. So induction therapy, it doesn't really have a lot of support except for potentially one SMART trial report more recently. So if you look at intraoperative therapy, and this is something that's a little more intriguing for surgeons in particular, because you can target areas of residual disease. So if you can't get tumor off the vertebral body, for instance, you can then target it with some kind of local treatment. And you can target it without tissue toxicity to normal tissue because you can isolate it. You have the whole chest open. Radiation cons. Intraoperative, by the way, we did that in San Francisco, and the mechanism for doing intraoperative radiation had this huge machine that had to sit over the patient, and there's always issues potentially with flexibility of moving the machine to where you want it to go, and also there was problems with keeping the patient's chest underneath this machine and keeping it sterile and getting infections. Interoperative chemotherapy has been used both intravenously and into the pleural space, and we're going to talk about that a little more in the next talk. It's potentially something that can be used. You put chemotherapy into the space where the tumor is, and it's going to be high doses theoretically in the area where the tumor is, and have less absorption into the systemically and have maybe less toxicity. And there is some data to support that, but there's not a lot, I can say. The problem is that there's added toxicity to having chemotherapy at the same time as surgery, and it's a single dose. So most chemotherapy drugs work better if you get multiple doses over a period of time. Post-op or intraoperative biologic therapies are starting to be looked at more, and we're going to hear about that more this afternoon, later today. Biologic therapies can target areas, again, residual disease. One of the biggest reasons, I think, to do surgery in this disease is that we can then have essentially the tumor microenvironment, the tumor bed open to be able to manipulate it and hopefully do biologic manipulations that will prevent it from growing back. Because in reality, when you're done with a pleurectomy or even an EPP, there's no visible tumor. So if you could keep it that way and there's only a few little cells that are microscopically left around the chest in those circumstances, if you can control the rest, which is a really minimal amount of disease, you can potentially control the tumor altogether. So you have a wide exposure of the tumor bed or residual tumor. You may be able to counter some of the possible growth effects when somebody's healing from an operation. A lot of the things that are focused in that area are for growth of tissue, for healing and that kind of stuff, and that can actually stimulate the tumor to grow as well, and so you can alter that. You may be able to use cellular therapy in the pleural space potentially to modify it long term, so that there's very focal effects and no other toxicity to the rest of the patient. The downside from doing biologic therapy is that, again, added toxicity. Added toxicity, and again, limited single dose, single application. And it could have effects on wound healing. So post-operative adjuvant therapies in terms of the diffuse thing, this is pretty much the same thing. It can be targeted after surgery to areas that we know have residual disease. Radiation is radiation. And it's possibly more successful against microscopic disease, so that's certainly an advantage. The cons are it's difficult to do with the lung in place, and for many people they say they can't do it with the lung in place, but as you'll hear later, there's really good ways now to do it with different types of 4D and tomotherapy. Patient tolerates it less well after surgery because of the double hit where they get surgery and then radiation. And chemotherapy basically is the same thing. Systemic effect gives you both local and distant disease control, that's a positive. And it's possibly better for microscopic disease, but there's a low response rate, and there's, again, more toxicity. So looking at everything, because from a diffuse nature, it poses unique challenges, both in surgical technique as well as what other therapies you can add before, during, or after surgery. One of the issues, I think, altogether is whether surgical therapy should be used at all. The real problem, and I think that I tell most patients this, is that I don't have any proof that surgery works, but in some other data that you'll see later, that in a very high percentage of patients we can remove all visible tumor, and if you do that, that's equivalent to a complete response from chemotherapy. So that's pretty effective treatment. The only problem is that this is not much other effective treatment to add on top of it to really control the tumor. So the real problem with the technique in surgery is that depending on what you do and what you choose to do, you can actually make the patient worse. So doing EPP sounds good, and I had actually a fellow surgeon of mine come back after seeing an EPP in another institution, and he said it just looked so neat afterwards. Everything was taken out. It looked so neat, like everything was gone, and unfortunately, though, the survival is not very good. And the biggest thing I think about EPP and the concept is that when you start becoming more radical, you're actually spreading the tumor to more areas of the body, which makes it even harder to control. At least if you keep it within the pleural space, you have at least a more targeted tumor volume. And certainly opportunities exist to take advantage of the access to the tumor bed microenvironment for this, and we're going to talk a lot about that today, both in the next few talks as well as this afternoon in the experimental talks by Dr. Wong and Dr. Jan Kilescu. We're going to talk about really looking at immunotherapy to be done either during the surgery or afterwards. They can target the tumor bed so that the tumor eventually will just not grow after the surgery because it's been treated with some kind of biologic agent. So that's pretty much it for the first talk. That's just an introduction. I guess that's it. I won't go any farther. So basically, I just wanted to give that talk just to highlight that the implications of a diffuse tumor, the difficulty, and but the opportunities, because I think, again, surgery, when you're doing these operations, it's kind of hard sometimes to imagine that you're doing any good when you're just scraping tumor off of all these different surfaces. And the question, I've had a lot of questions over the years about whether we should be doing this or not. But I think more recently with kind of resurgence of immunotherapy and other biologic therapies, targeted therapies that people are now developing based on genetic abnormalities that are present in mesothelioma and have been identified as potential mechanisms for the tumor to grow, I think we now have an opportunity to kind of do an operation which removes the gross disease and then seeds the entire tumor bed with something new that will prevent it from growing back. So I think that there's an opportunity in the near future to really make a difference in these patients. I think I have a couple minutes for